I treat my T's like I would my B's, but I swap maybe one drug out.
Welcome to Dogtors Without Borders, the official podcast of the MSU College of Veterinary Medicine. I'm your host, Kristen Lair, and today we're diving into the world of cancer research. Joining us is Dr. Kurt Zinn, Professor, Hickman Family Chair, and Director of the Clinical Innovation Program, and Dr. Alison Masyr, Assistant Professor of Medical Oncology. Dr. Zinn and Masyr, welcome to the program.
Thank you. Thank you for having me.
Great to be here.
To get us started, please tell us when you each decided to become a veterinarian.
I didn't decide to become a veterinarian until after I'd graduated college, which I think is maybe a little bit unusual. It seems like a lot of people kind of tend to know from day one. I had always been interested in biology. I majored in that in college, and I had come to realize that I wanted to do something where I could feel like I was very hands-on, and kind of get like immediate gratification. I was worried that if I did something that was more heavily research based, that I wouldn't get as much of an immediate satisfaction out of it. And so initially I thought I was going to go to dental school and started on that path, and then realized that I was more interested in treating the entire individual. And I'd always been interested in veterinary medicine, but was, I don't know, nervous about letting myself get too attached to it. I started working in a emergency and referral practice and had never seen specialty medicine in the veterinary realm. I didn't realize it existed. And seeing that, I think, really opened up a whole new world to me. And that experience is what then inspired me to go to veterinary school.
Well, I knew I wanted to be a veterinarian from a very early age because I grew up in a mixed practice. My father had a 75% large animal, 25% small animal practice, and I rode with him starting when I was about 5 years old. My earliest memory is cutting stitches for him while he was sewing up an animal on a farm. Our practice was a little different. We had the practice in the basement of our house. We lived outside of town on 6 acres. And so the practice in the basement, and we were always recruited to answer the phone and to take messages and call my dad on the radio and tell him where to go next when he was out visiting farms. So, of course, every time I was at a farm, the farmer would ask me, "What are you going to be when you grow up?" And so I knew what the answer was, and I really enjoyed the practice, and knew that that's what I wanted to do from a very early age. But what I realized as an undergraduate was my love for the research part of things. So when I got accepted into vet school, I immediately started doing research and became interested in that aspect of veterinary medicine. And it was at a time where research was just starting to be done by veterinarians, and it greatly expanded, and there were many opportunities presented, and I'm really glad that I went down that road.
Sounds like your childhood was the real James Herriot experience.
Yeah, it really was. Animals would show up at all times of the day and night, unannounced. And my father was also a DV and PhD, so he liked to do more than the typical veterinarian. He made his own vaccines in the basement, and he did his own bacteriology, sensitivity. Doing cultures and sensitivity was part of his business because it was hard to send samples off in those days. So, yeah, it was a really fun experience.
Yeah, that gives a lot of context, and it makes a lot of sense as to how you ended up where you are.
Yeah, I always enjoyed being around my father's veterinary friends too. The veterinarians are a special group, and it's always fun to be around veterinarians that have so many problems to solve for animals, and animals can't talk and tell how they're feeling, and you have to determine that in other ways.
Yes, absolutely. So clinical research, which is most of the research that I engage in, means that we are using client-owned animals who have a cancer that has developed. We haven't put that cancer in them. They just come in and they say, my dog has this disease, and we say, well, we've got a trial that we're working on for that. And so we enroll patients that fit select criteria, and then we provide them with treatment and follow them with various tests and measurements through a certain period of time. That's the broad strokes of clinical research. Now, when we say an animal model, that can mean a couple of different things. So the dog that walks in that has lymphoma, that just developed lymphoma, that dog can serve as a model for the human equivalent of the disease. But there are also models that are made in a laboratory setting where, let's say, a mouse may be injected with tumor cells and then develop that tumor. That's also a model. It's just not a spontaneously developed model. But when Dr. Zinn and I are talking about the patients that I treat as serving as models, we're referring to those patients that have just developed a cancer for whatever one of a billion reasons. And now we can try to alleviate their disease with this new therapy.
To find these animals that have the spontaneous developed cancer, are there veterinarians referring them to you? How does that work? How do you find these patients?
That's a great question. I think that a lot of it is to try to make your trials as accessible as possible. And that means coming at it from a couple of different angles, right? So some of that is I reach out to the other oncologists in the state, because certainly they're a rich source of these potential trial enrollees. We also reach out to our referring veterinary community, let them know what trials we have going on, and especially as new ones roll out. And then we also try to let people know via social media. We also have our clinical trials page on our hospital website to let them know about different trials that we have going on. I also do my best to try to put our trials on. There's a national database run through the American Veterinary Medical Association. So I do try to put our trials up there just in case there's someone. I mean, every now and then you get someone who's like, I'm coming from Arizona all the way to Michigan, and that's great. But maybe there's someone in Indiana or Illinois or Ohio who may not think of, oh, I'm going to look at Michigan State's website because it's not the state that they live in, but they're near enough that it's not too bad of a hop, skip, and a jump over here.
I'd like to make one comment about the models and what we do on the bench, side differently from what Dr. Masyr does. We often are working with new agents or repurposed agents for targeting cancer. And one of the things we like to do is to grow the cancer cells in vitro in a petri dish under conditions where they'll grow colonies of cancer cells. And what we do is we can determine if our agents will bind to those cancer cells in vitro, and more importantly, when we're working with a therapeutic agent, will our targeted agent actually kill the cancer cells and prevent them from growing into colonies of cancer? So we call that clonogenic assays, and we're actually doing that now in a project that Dr. Masyr and I are working together on. We were able to obtain 6 canine bladder cancer cell lines, and we've characterized them for the agent that we're using, and we're doing these kinds of studies to determine, is the treatment working in vitro? And it's a good way to know that it's a great candidate to move forward to do the same studies in the dogs with the spontaneous tumors.
So that means you're studying whether or not the treatments that you're developing kill the cancer cells while they're still in a petri dish.
Exactly.
Bringing that kind of into the clinical picture, I think it's important to know that anything that goes into a client-owned animal, it has taken many, many steps to get there, right? So I think that what you described, Dr. Zinn, is a great example of a lot of times where these things start, right? They start in a petri dish. Now we know that obviously a petri dish is not a dog, right? There's a million gajillion different changes that happen between a petri dish and a full animal. But after you see something be effective in a petri dish, then you can start to say, well, what if I put it into, let's say, that mouse that I mentioned before, inject tumor cells into a mouse and see if the treatment works there. And if it works there, then we continue to scale up until we get to client-owned animals, because we really want to be very conscientious of how we treat our animals on our clinical trials. We want to make sure that what we recommend is ethical to our clients and ethical for our patients, because for as much as our clients are advocates for their pets, we also want to be sure that, coming from the scientific side of things, that we're also advocates for them as well.
I was reading about your study with the peripheral T-cell lymphoma, and you're comparing a couple different treatments for how you can improve the care for the dogs. And I'm just curious, I do remember a case of lymphoma when I was a veterinary student, and I remember we treated the dog with adriamycin, and I remember seeing that dog later, and the lymph nodes were really large and swollen when we first diagnosed the disease, and then later they just shrank down really well, and the dog tolerated it really amazingly. I was so surprised. That's my total experience. I wonder is it a common disease? Do you see a lot of cases here at the clinic?
Of lymphoma, yes. Now, specifically peripheral T-cell lymphoma, which that trial is for, it's a smaller subset of the broad lymphomas, right? So lymphoma is one word that comprises many, many diseases, which can have widely different behaviors, treatments, prognoses, etc. So broadly, yes, we see a lot of lymphoma, especially in dogs and cats. It's about 20% of all malignancies. So we do see a fair number of them. You're absolutely correct that dogs, and especially cats, tolerate chemotherapy in a way that's much different than what we think of with people. And part of that is probably that dogs and cats just have an incredible reserve. Meanwhile, I feel like I get a paper cut and I'm like, should I call out for the day? But also, we're giving them much lower doses, and we're not necessarily treating with several chemotherapy agents all at once, the way we think of with people. And really, that's because so much of our goal in veterinary oncology is quality of life, right? We all want our pets to be with us forever. We know that that's not realistic, and we still want to make sure that whatever that amount of time is, it's the best quality time that it can be, right? We never want to sacrifice quantity for quality. So because of that, it means that's why we use those lower doses. We space treatments out more and really try to make sure that whatever additional time we get is as good as it could be.
What made you decide to study peripheral T-cell lymphoma specifically?
The majority of canine lymphoma cases are B-cell lymphoma, so usually diffuse large B-cell lymphoma, which is actually a very common form of lymphoma in people. So another example of a really valuable animal model. But a smaller subset of the peripheral nodal lymphomas we see in dogs are T-cell mediated. So the difference between B-cell and T-cell is just the type of lymphocyte that's causing the lymphoma. And the reason that this differentiation is valuable is that we have a general understanding that B-cell lymphoma tends to respond better and for longer to most of the chemotherapies that we have, versus T-cell lymphoma can be tougher for us to achieve and maintain a remission. And if you ask, I kind of joke that if you ask 3 different oncologists, you'll get 5 different opinions on how they treat their B-cell lymphomas versus their T-cell lymphomas. Some people say, well, the evidence for treating them differently isn't strong enough, so I treat them the same. Some people say, well, there is some evidence, so I treat my T's like I would my B's, but I swap maybe one drug out. And then there are some people who go as far as to say, I give my T-cell lymphomas a fully different protocol. And ultimately, the publications, the scientific evidence that those decisions are being based off of are several studies that were retrospective. So they're looking back at records, which is valuable in that it can amass a larger group of patients. But the limitations are that none of that treatment was standardized. So that makes it hard to draw forward conclusions. And those studies were what we describe as single arm. So those were dogs that had T-cell lymphoma, but only received what is the LOP treatment in the trial that we're doing. They didn't compare it to a standard of care like a CHOP arm. And so this study is essentially just trying to say, can we look at this question that oncologists have been asking for years and years and years and just try to ask it in a way that's maybe cleaner? So if we take dogs with T-cell lymphoma and randomly assign them to either receive CHOP, which is very tried and true chemotherapy protocol, even used for some first line in people with lymphoma, and then also the ones that don't go into that CHOP arm randomly get placed into a LOP arm. Now, the reason that those rhyme is because they have some of the same drugs involved. So there is a little bit of overlap there. But then we can make sure that we follow these dogs consistently so that we can really try to draw a conclusion and hopefully answer that age-old question of, are they even different? Is one superior? The reason that I think that that would be ultimately very valuable is that a lot of times people hear, hey, your dog has T-cell lymphoma, or I suspect your dog has T-cell lymphoma, and here's why that could be worse. And I think a lot of times people say, well, if it's going to be worse, then I don't want to do anything, or I want to be very, very conservative in my treatment, which is completely fair. That said, if we could really try to differentiate if there's a protocol that's better for these dogs, then maybe we get to say, hey, your dog has T-cell lymphoma, and here's how that's slightly different, but perhaps not as dire or as poor of a prognosis as we had previously been giving. And it would be great to have a little bit more confidence behind that recommendation.
CHOP and LOP. Those sound like acronyms to me. I wonder if you could, explain what those mean, what those refer to, and exactly what is the difference between CHOP and LOP.
Yeah, absolutely. So you are correct that they are acronyms. So they each essentially stand for the 4 drugs that are in each protocol. So I just want to mention that LOP has 2 Ps. So they both have 4 letters. And CHOP stands, I will tell you that the letters don't get too connected to the letters because they don't match up perfectly. But the C in CHOP stands for cyclophosphamide, which is an oral chemotherapy drug. The H is hydroxydonorubicin, which we just refer to as doxorubicin. O was previously called oncovin, which we refer to as vincristine. And then the P is prednisone, which is a steroid that you certainly don't need an oncologist to prescribe, is used in people, very effective treatment for lymphoma. Versus LOP stands for L, which is lomustine, O, which is again that oncovin vincristine. One of those P's is prednisone, and then the last P is an oral chemotherapy called procarbazine. Now, I would say that both of them are delivered in multiple 4-week cycles. The major difference, I would say, is that CHOP is usually every week versus LOP. The way that we're doing it for this trial is every other week. There are different ways that you can give LOP, but that's what I've decided to do for this study. Eventually, CHOP does space out into every other week, but just that beginning first 10-ish weeks or so is a little bit more compressed with the CHOP protocol. But besides the scheduling differences, the difference in the protocols is really who is the heavy hitter of the protocol. So in CHOP, doxorubicin is the heavy hitter, right? It's who you want to step up to the plate to, bring hit a grand slam kind of thing. And doxorubicin on its own can be a really potent chemotherapy drug for lymphoma. But the question that we've been asking for so long is, do T-cell lymphoma dogs do better with a protocol that doesn't revolve around doxorubicin? Maybe that for T-cell lymphomas, that's not a heavy hitter. Maybe it's got a much lower batting average. So the drug that we've been wondering might be better for T-cell lymphomas is that lomustine drug. So that's the heavy hitter in the LOP protocol.
Do you think that the side effects from one of the protocols might be less than the other protocol? I mean, are you expecting the dogs to tolerate both protocols equally well?
I've given both protocols many, many times. And I would say that broadly speaking, the severity of side effects is similar. It's just that each of these drugs is kind of their own unique snowflake. So they all have a slightly different side effect profile. So the actual side effects themselves may be slightly different, but I don't necessarily think that they're worse with one protocol over another.
What kind of side effects would we expect to see with these treatments?
For most chemotherapy, we think about really the side effects that we think of with people undergoing chemotherapy. It's just about the frequency of those side effects and the severity of those side effects that really separates veterinary oncology chemotherapy side effects from those of human oncology. So broadly speaking, we think about bone marrow side effects, as in low white blood cell count. That can make a dog feel unwell. It can get to a point where they might be low enough that they really can't protect themselves from an infection. They might develop a fever. I would say that that's pretty uncommon. Most of the time, it either doesn't happen or it's happening and dogs have no idea. The second broad category that we think of is gastrointestinal upset. So that's, some vomiting, diarrhea, lack of appetite. Again, most cases, either it does not happen at all, it's mild, and we can manage it with easily prescribed medications. It's the rare case where it's severe enough that we say, ooh, I really think that this animal would benefit from a short hospital stay, maybe to rehydrate them, that kind of thing, give them some anti-nausea medications. And then with people, we think of hair loss. With our veterinary patients, most of the time we don't see that. Their hair cycle is slightly different than our hair cycle is. And so most of our patients don't certainly go bald. Most of them don't even get thin in the coat. Every now and then you'll meet a poodly doodly dog or maybe a tiny white fluffy dog who gets really thin. There's like maybe one a year that goes bald. So I actually have a patient right now who just did that. So I've just been telling all my subsequent clients that their dog isn't going to be it because it only happens once a year and I've already got one on the books. So
How many animals do you think you'll need to recruit in both of these cohorts to be able to know if one is better than the other?
yeah, that's a great question. So that's a question that we try to answer before we start enrolling, right? The best clinical trials are clinical trials that you've thought about well in advance and you've tried to consider every issue from every possible angle. So that way, when you get there, hopefully you already have an answer, even though inevitably new things always pop up. But the question of, well, how many is it going to take for us to substantially make a claim one way or the other? That's something that we figure out by doing what's called a power analysis before starting the trial. And so that power analysis is based on what we're trying to demonstrate and what has previously been demonstrated. And so for this study, we're trying to recruit essentially 21 dogs in each arm. So a total of 42 dogs.
Great. That's very interesting to know. I'd like to go back real quickly to the side effects again. And I wonder when one of the brings a patient to be part of your study, if you recommend that they don't do anything on their own to treat the animal. And what I'm talking about is, now that cannabis is legal in Michigan, do you ever encounter an owner that's wanting to give their dog a gummy just to help them get through their cancer treatment, or is that something that you encounter in practice?
When you say ever, you mean like in the last hour or just in
Just
general?
general.
Yes, we certainly do. We certainly have clients who come and they tell us that their pet is already receiving some sort of cannabis product, which I'm going to say like hemp, CBD, everything under that umbrella. And then we have people who might start that afterwards. I I don't know that I make a really strong statement either way because I don't feel like we have that information yet. But what I will say is a couple of things. One, there's not a whole lot of specific regulation around these pet products. So it's hard for us to know, are there other things in that product that we maybe don't want to be there? Is the amount of whatever substance you're trying to give truly the amount that's in there? And then from a broader treatment standpoint, a lot of these are in an oil formulation. How does that play in? A lot of dogs like to develop pancreatitis, often as a result of fat ingestion. And so, does receiving an oil have an impact there? And finally, cannabis has a lot of different mechanisms of action. And one of those is antioxidation properties. And, we hear a lot about antioxidants are good, they're going to stop us all from aging. But something to keep in mind is that several of our chemotherapy drugs, the way that they kill cancer cells is by creating oxidants. And so, is there a potential that providing a drug that tries to kill cancer by creating oxidants while also giving an antioxidant could mitigate the effect of the chemotherapy? I think that's a question that a lot of people are asking. I think we don't have clear answers in terms of getting from the level of a petri dish into a real live animal. But that question is still out there. And so, given that I can say, I know that doxorubicin has this percent effectiveness against this particular disease, and I have no idea what hemp, cannabis, CBD does for this particular disease, I really leave it up to the client to make that choice. I think that when you have an animal, a pet with cancer, you feel incredibly helpless. And I think that there are a lot of people that are willing to take advantage of that. And if we just personify the internet certainly is very willing to take advantage of that. And so I tell my clients that I really try to limit my recommendations to things that I feel like I can back up. And that doesn't mean that maybe one day our opinion won't change. And maybe that'll be our first line recommendation. It's just that that day isn't today.
But your personal recommendation for your clinical trial would be to probably not use cannabis so that you wouldn't have a complicating factor. Would that be true to say?
Yeah, absolutely. Again, the whole reason we're doing this study is to try to get the cleanest data possible. And it will be clean as it could be if everyone is treated the same way. And so, yes, that would include excluding supplements like CBD.
I wonder if you could comment on the origin of these cancers, if you think they're all spontaneous or if there's some other factor, some exposure that causes these cancers to occur. I mean, what do you think about that?
Yeah, I think that's a question that people have been asking for a very long time. And I think that the answer is very complicated and, short answer, unanswered. I think that cancer is a combination of two things. It's partly what you're born with, genetics, and what you're exposed to over time, your environment. And some cancers might be purely one or purely the other, but chances are most of them are the meeting of the two, the overlap in that Venn diagram. And so with lymphoma, because lymphoma in dogs is such a great model for the disease in people, it's a question that people have asked a fair bit in dogs. There are several studies looking at, does proximity to different kinds of industrial settings or exposure to herbicide products, or I think There might be one on water composition. Are these things that have any sort of influence on the development of lymphoma? And several of those studies have found that no, there isn't. Some have found yes, and sometimes there's a yes and a no on the same exact exposure, and so that makes making a determination really tricky. And I think that with these broad causal epidemiologic studies, it's really hard to make a hard and fast answer. Um, with lymphoma, I think it's clear that there is a genetic component because while any dog breed can be susceptible to lymphoma, there are some breeds that we see more classically. And so that means that there has to be a genetic component there. But because any breed, purebred, mixed breed, any breed can develop lymphoma, it also means that there's probably an environmental influence involved, whatever that may be.
When you're done with this study and you've determined which treatment is best for the dogs, how do you think that might be useful for translation over to humans? So how will that help to benefit human treatments in the future?
Well, peripheral T-cell lymphoma, from my veterinary understanding, is not as common in human medicine. That said, it does seem like it is a more challenging disease to control than its B-cell counterpart, which is similar to what we see. Um, I think that there's a lot of studies that we do that have very strong translational value into human medicine. I think that here, this particular study may not be as translational as some of our others. And I say that mostly because human oncology has the benefit of such a wider array of anti-cancer therapies than what we have in veterinary medicine. And so I imagine that medical oncologists who treat people really, they just have a lot more at their disposal for the treatment of peripheral T-cell lymphoma than what we have. So I imagine that finding out that, let's say LOP is better than CHOP. Let's just say, I don't know that. I don't know that that information would really forward what they do so much because they've got a full walk-in closet, whereas I have like a shelf.
Understood. Well, we hope that that shelf can be expanded to multiple shelves in the future with the work that we're doing, to develop new strategies for treating cancers.
Yeah, absolutely. And certainly there are other projects that we have currently going on, even some that you and I are working on, that I think have much more clear translational value.
Right. And we hope that we can take some of these human drugs that will work in dogs and be able to repurpose them for other treatments like we're doing for the canine bladder cancer study.
Yeah, absolutely. And bladder cancer in dogs also can serve as a model for bladder cancer in people, not necessarily the most common forms, but the most aggressive, severe forms. So there's value there as well.
Absolutely. Dr. Masyr, I wonder if you could offer some advice to a veterinary student or a pre-vet student in terms of what you would suggest in terms of a specialty in oncology, what you would recommend and what you'd ask them to consider for that specialty.
Yeah, so I think for a pre-veterinary student, probably one of the most important things that you can do, besides, of course, getting good grades in your studies, is to also try to have a diverse array of experiences. So that can mean, let's say, working in an ER referral setting, but also have experience in a GP setting, a general practice setting. That also can mean having experience with large animals. So personally for me, I mentioned earlier that I worked in an emergency and referral practice for about 1.5 years, 2 years before I went to veterinary school. At the same time, I also shadowed in a general practice setting just to get a sense of how that was different. I also I grew up in a very urban area, so there weren't a whole lot of large animals to be found. And so I volunteered with a therapeutic riding organization. And so that gave me the opportunity to have a little bit of experience with equine handling and husbandry, those kinds of things. So I think making sure that you have a wide array of experience, because not only will that be helpful once you're in veterinary school, but also will kind of open you to the different kinds of ways to be a veterinarian. And then I think in terms of what I would recommend to someone considering a specialty, I think the big thing is to really try to keep an open mind. I think it's really easy to get tunnel visioned on a particular area and just try to really throw yourself into that. And there certainly is a time and a place for that. I don't know that it's, let's say, your first year of veterinary school, because ultimately the goal of veterinary school is to become a good veterinarian. And then you can add to that after that. But you will only be a good specialist if you can build on the foundation of being a good, well-rounded practitioner from the get-go. So I think for as much as, I knew I wanted to do small animal and I was more in the medicine kind of mindset than, let's say, a surgery mindset, I still listened when I learned all about hoof abscesses in cows, right? Because that was part of what I needed to do to become a well-rounded veterinarian. And then once I had accomplished that, I was able to dive into a particular area and really kind of fall down the rabbit hole that is specializing. So in the same vein, Dr. Zinn, I wonder if you could provide a little bit of advice, wisdom to the prospective veterinary student, the current veterinary student, maybe even a veterinarian who's interested in changing things up a little bit. What are the actions that someone could take to develop a career like yours, which is predominantly science, benchtop, research-based?
Yeah, that's a great question. There's a lot of research opportunities for graduate studies where a veterinarian could be accepted into a PhD program, such as one that we have here in Michigan State, the CMIB program, where they could study for a PhD and then, do more hands-on research. There's also opportunities for getting dually enrolled into a DVM PhD program. We have those as well. I would say investigate what's of interest, what type of specialty. There's a lot of variety. It's not just oncology, but it's also infectious diseases and many different research opportunities that beyond oncology for sure. So it really depends on what the veterinarian's research interests are. But veterinarians have traditionally been very welcomed into the research area because of their great experience and all the different skills that they have. So, and I should add that these graduate programs are supported with stipends, and insurance, and it's not like you have to go back to living in like you were when you were a veterinary student. You're much better supported in a PhD program. So if there's a fear in that respect, don't worry about it, because there's funds available, from the various funding agencies for it, and specifically for veterinarians as well. There's opportunities for veterinarians to re-enter into the research career. So a huge number of opportunities in the research side of things.
Dr. Zinn and Dr. Masyr, thank you so much for sharing your knowledge and experiences with us.
Thank you.
Yeah, thank you for having us.
That wraps up our conversation with Dr. Kurt Zinn and Dr. Alison Masyr. We hope you found their insights as valuable as we did. If you enjoyed this episode, be sure to follow us and share. And as always, stay connected with the MSU College of Veterinary Medicine. Thanks for listening, and we'll see you next time.